Question 1. What is the recommended initial intravenous/intraosseous (IO) dose of epinephrine for an adult in cardiac arrest? A. 0.1 milligrams. B. 0.5 milligrams. C. 1 milligram. D. 2 milligrams. Answer: C. 1 milligram. This question tests your knowledge of the essential drug doses in cardiac arrest, specifically for epinephrine. The keyword initial dose highlights the first amount given in an emergency. In adult cardiac arrest, epinephrine is given at a dose of 1 milligram every 3 to 5 minutes to help restore spontaneous circulation by increasing myocardial and cerebral blood flow. For example, if a patient collapses and is found to be in ventricular fibrillation, epinephrine is a critical medication administered during CPR after initial defibrillation attempts. Remember, 1 milligram of epinephrine is the standard starting dose in cardiac arrest for adults. Question 2. A patient presents with symptomatic bradycardia. Which medication is the first-line drug for this condition? A. Adenosine. B. Atropine. C. Amiodarone. D. Lidocaine. Answer: B. Atropine. This question focuses on the immediate management of symptomatic bradycardia, and first-line drug is the key phrase here. Atropine is the initial medication of choice for symptomatic bradycardia because it blocks the action of the vagus nerve, which can slow the heart rate. For instance, if a patient's heart rate is 30 beats per minute and they are hypotensive and dizzy, atropine 0.5 milligrams would be the first medication to administer. Always remember that atropine is your go-to medication for a slow heart rate that is causing problems. Question 3. What is the recommended initial 4/IO dose of amiodarone for pulseless ventricular tachycardia, VT, or ventricular fibrillation, VF, that is unresponsive to defibrillation? A. 150 milligrams. B. 300 milligrams. C. 450 milligrams. D. 600 milligrams. Answer: B. 300 milligrams. This question addresses the antiarrhythmic drug of choice for shock-refractory cardiac arrest rhythms. The key phrase initial 4/IO dose points to the first amount administered in this critical scenario. When ventricular fibrillation or pulseless ventricular tachycardia persists despite defibrillation and epinephrine, amiodarone 300 mg 4/IO is administered as the first dose to help stabilize the heart rhythm. For example, after 2 shocks and an epinephrine dose, if a patient remains in VF, 300 mg of amiodarone should be given. Think of amiodarone 300 mg as the standard initial dose for persistent VF/pulseless VT. Question 4. What is the recommended initial 4 dose of adenosine for stable, narrow-complex supraventricular tachycardia, SVT? A. 3 mg. B. 6 mg. C. 9 mg. D. 12 mg. Answer: B. 6 mg. This question tests your knowledge of adenosine's role in specific arrhythmias, with initial 4 dose and stable, narrow-complex SVT being the critical clues. Adenosine is the first-line drug for stable narrow-complex supraventricular tachycardia because it briefly blocks the AV node, often interrupting the re-entry circuit causing the SVT. For example, if a patient has a heart rate of 180 bpm with a regular narrow QRS and is stable, adenosine 6 mg 4 push is the initial treatment. Remember, 6 mg is your first attempt with adenosine for SVT. Question 5. Which medication is indicated for the treatment of torsades de pointes? A. Adenosine. B. Atropine. C. Magnesium sulfate. D. Sodium bicarbonate. Answer: C. Magnesium sulfate. This question asks about the specific drug used for a polymorphic ventricular tachycardia known as torsades de pointes. Recognizing torsades de pointes is the crucial keyword here. Magnesium sulfate is the primary treatment for torsades de pointes, an arrhythmia often associated with prolonged QT interval, because it helps to stabilize cardiac cell membranes and reduce abnormal electrical activity. For instance, if an ECG shows the characteristic twisting QRS complexes of torsades, 1 to 2 grams of magnesium sulfate 4 should be administered. Always connect magnesium sulfate directly to torsades de pointes. Question 6. A patient is experiencing chest pain suggestive of an acute coronary syndrome, ACLS. Which medication is indicated as part of the initial management, provided there are no contraindications? A. Furosemide. B. Aspirin. C. Lidocaine. D. Naloxone. Answer: B. Aspirin. This question addresses the initial drug therapy for suspected acute coronary syndromes, with initial management and ACS being key. Aspirin is a cornerstone of initial ACS management because of its antiplatelet effects, which reduce clot formation in the coronary arteries. For example, if a patient complains of sudden severe chest pain, administering 162 to 325 milligrams of chewable aspirin is a vital early step unless they have a known aspirin allergy or active bleeding. Remember to think of aspirin as one of the first medications to give for chest pain suggestive of a heart attack. Question 7. What is the maximum total dose of atropine that can be given for symptomatic bradycardia? A. 1 milligram. B. 2 milligrams. C. 3 milligrams. D. 4 milligrams. Answer: C. 3 milligrams. This question tests the upper limit of atropine dosage for symptomatic bradycardia. The keywords maximum total dose are crucial for understanding the safety parameters of this drug. While the initial dose of atropine is 0.5 milligrams, it can be repeated every 3 to 5 minutes up to a total maximum dose of 3 milligrams, which is considered the point at which full vagal blockade is achieved. For instance, if a patient receives 0.5 milligrams and remains bradycardic, subsequent doses can be given until 3 milligrams total is reached or heart rate improves. Be sure to stop atropine administration once the maximum dose of 3 milligrams is reached, as further doses are unlikely to be beneficial. Question 8. A patient has a suspected opioid overdose with respiratory depression. Which medication should be administered? A. Flumazenol. B. Naloxone. C. Atropine. D. Dextrose. Answer: B. Naloxone. This question asks about the specific antidote for opioid overdose. The critical clue is opioid overdose with respiratory depression. Naloxone is a pure opioid antagonist that rapidly reverses the effects of opioid medications, especially respiratory depression, which is life-threatening. For example, if a patient is found unresponsive with pinpoint pupils and slow, shallow breathing, naloxone should be given immediately. Always remember naloxone is the specific drug for opioid overdose. Question 9. What is the recommended initial 4/IO dose of lidocaine for refractory ventricular fibrillation, VF, or pulseless ventricular tachycardia, VT, if amiodarone is not available or contraindicated? A. 0.5 to 0.75 mg/kg. B. 1 to 1.5 mg/kg. C. 2 to 3 mg/kg. D. 3 to 4 mg/kg. Answer B. 1 to 1.5 mg/kg. This question tests your knowledge of an alternative antiarrhythmic drug for shock-refractory ventricular rhythms when amiodarone is not an option. The keywords are initial 4/IO dose, refractory VF/VT, and if amiodarone is not available or contraindicated. Lidocaine is a second-line antiarrhythmic that can be used for persistent VF/pulseless VT, with an initial dose of 1 to 1.5 mg/kg, especially if amiodarone is unavailable. For instance, after unsuccessful defibrillation attempts and epinephrine, if amiodarone is contraindicated for a patient, then lidocaine 1 to 1.5 mg/kg would be administered. Remember that lidocaine serves as an alternative to amiodarone for these life-threatening rhythms. Question 10. Which medication is used to reverse symptomatic hypoglycemia in a patient who is unconscious and cannot take oral glucose? A. Glucagon. B. Dextrose 50%. C. Insulin. D. Epinephrine. Answer B. Dextrose 50%. This question asks about the emergency treatment for dangerously low blood sugar in an unresponsive patient. The keywords are symptomatic hypoglycemia, unconscious, and cannot take oral glucose. Dextrose 50%, D50, is the immediate treatment for severe hypoglycemia in an unconscious patient because it rapidly provides glucose directly into the bloodstream, raising blood sugar levels. For example, if a diabetic patient is found unconscious and their blood glucose reading is 30 mg per deciliter, D54 should be given. Always remember that dextrose 50% is for unconscious patients with low blood sugar. Question 11. What is the recommended initial 4/IO dose of adenosine if the first dose was unsuccessful in converting stable, narrow complex SVT? A. 3 mg. B. 6 mg. C. 9 mg. D. 12 mg. Answer D. 12 mg. This question builds on the previous adenosine question, focusing on the second dose if the first is ineffective. The keywords initial 4/IO dose and if the first dose was unsuccessful are critical. If the initial 6 mg dose of adenosine fails to convert stable narrow complex SVT, a second dose of 12 mg 4/IO may be given. For example, if a patient receives 6 mg of adenosine for SVT and the rhythm persists, the next step is to administer 12 mg. Always remember that adenosine's doses escalate from 6 mg to 12 mg if needed. Question 12. A patient with suspected acute coronary syndrome develops pulmonary edema and has a systolic blood pressure of 160 mm of mercury. Which medication may be administered to reduce preload and afterload? A. Norepinephrine. B. Furosemide. C. Dopamine. D. Atropine. Answer B. Furosemide. This question relates to managing a specific complication of ACS, pulmonary edema, with pulmonary edema and reduced preload and afterload being key. Furosemide, a loop diuretic, is often given in this scenario to help remove excess fluid from the lungs, reducing preload, and can also cause venodilation, reducing preload and afterload, which benefits cardiac function. For example, if a patient with ACS develops shortness of breath, crackles in their lungs, and elevated blood pressure, administering furosemide can help alleviate the fluid overload. Think of furosemide as a way to dry out the lungs and ease the heart's workload in heart failure and pulmonary edema. Question 13. Which medication is indicated for hypotension resulting from a suspected calcium channel blocker or beta blocker overdose? A. Sodium bicarbonate. B. Calcium chloride. C. Magnesium sulfate. D. Adenosine. Answer: B. Calcium chloride. This question tests your knowledge of specific antidotes for drug overdoses. The critical keywords are hypotension, calcium channel blocker, and beta blocker overdose. Calcium chloride is indicated in cases of calcium channel blocker or beta blocker overdose because it can help overcome the cardiac depression caused by these medications by increasing myocardial contractility and improving electrical conduction. For instance, if a patient has severe bradycardia and hypotension after taking too many beta blockers, administering calcium chloride might improve their condition. Remember, calcium chloride can be a lifesaver in certain drug overdoses affecting the heart. Question 14. What is the primary indication for the use of sodium bicarbonate in cardiac arrest? A. Routine use in all cardiac arrest. B. Hyperkalemia or tricyclic antidepressant overdose. C. Asystole that is unresponsive to epinephrine. D. Symptomatic bradycardia. Answer: B. Hyperkalemia or tricyclic antidepressant overdose. This question targets the specific, limited indications for sodium bicarbonate in ACLS. The keyword primary indication emphasizes its narrow use. Sodium bicarbonate is generally not recommended for routine use in cardiac arrest. Instead, it is reserved for specific situations like severe metabolic acidosis due to hyperkalemia or tricyclic antidepressant overdose, where it helps correct pH and counter the drug's effects. For example, if blood tests reveal extremely high potassium levels in a patient in cardiac arrest, sodium bicarbonate would be a considered treatment. It's important to know that sodium bicarbonate is used only in very specific circumstances, not as a general treatment in cardiac arrest. Question 15. A patient is stable with wide complex tachycardia of unknown origin. Which medication might be considered if adenosine is ineffective and expert consultation is unavailable? A. Atropine. B. Epinephrine. C. Amiodarone. D. Norepinephrine. Answer: C. Amiodarone. This question explores drug options for wide complex tachycardia when initial treatments or expert consultation are limited. The key clues are stable with wide complex tachycardia of unknown origin and if adenosine is ineffective and expert consultation is unavailable. Amiodarone is often considered for stable wide complex tachycardia, presumed ventricular tachycardia, because it is an effective antiarrhythmic for both ventricular and supraventricular arrhythmias. For instance, if a patient has a wide complex rhythm at 150 BPM and is stable, and initial adenosine attempts don't work, amiodarone might be chosen to help convert the rhythm. Amiodarone is a versatile antiarrhythmic for unstable or difficult to treat tachycardias. Question 16. What is the recommended infusion dose of epinephrine for a patient in profound shock, not cardiac arrest, requiring vasopressor support? A. 0.01 to 0.05 mcg/kg/min. B. 0.1 to 0.5 mcg/kg/min. C. 1 to 10 mcg/min. D. 2 to 20 mcg/min. Answer: D. 2 to 20 mcg/min. This question differentiates epinephrine use in shock from its cardiac arrest application, with profound shock, not cardiac arrest, and vasopressor support as key. For profound shock, epinephrine is administered as a continuous 4 infusion at doses typically ranging from 2 to 20 mcg/min to achieve vasoconstriction and improve blood pressure. For example, if a patient remains hypotensive despite fluid resuscitation, a continuous infusion of epinephrine might be started to maintain adequate perfusion. Remember that epinephrine is used as a continuous infusion to support blood pressure in shock, unlike the bolus dose in cardiac arrest. Question 17. Which medication should be administered to a patient with acute decompensated heart failure and severe pulmonary edema with a systolic blood pressure of 80 mm of mercury? A. Nitroglycerin. B. Furosemide. C. Norepinephrine. D. Morphine. Answer: C. Norepinephrine. This question focuses on managing acute heart failure with shock. The crucial details are acute decompensated heart failure, severe pulmonary edema, and a very low systolic blood pressure of 80 mm of mercury, indicating hypoperfusion. In this scenario, the priority is to raise the blood pressure to ensure adequate perfusion, and norepinephrine is a potent vasopressor indicated for distributive and cardiogenic shock to increase systemic vascular resistance and blood pressure. For example, if a patient is in cardiogenic shock with fluid overload, norepinephrine would be chosen to support their blood pressure while other measures address the fluid. Always prioritize blood pressure support with vasopressors like norepinephrine in hypotensive shock. Question 18. What is the typical adult dose of naloxone for opioid overdose in a non-cardiac arrest setting, e.g., patient with respiratory depression but breathing? A. 0.1 mg 4. B. 0.4 mg 4/IM/IN. C. 2 mg 4/IO. D. 4 mg IM/IN. Answer: B. 0.4 mg 4/IM/IN. This question delves into the dosing of naloxone in a common overdose scenario. The keywords typical adult dose and non-cardiac arrest setting, e.g., patient with respiratory depression but breathing, differentiate it from the cardiac arrest dose. The recommended initial dose of naloxone for opioid overdose in a non-cardiac arrest setting is 0.4 mg given intravenously, intramuscularly, or intranasally, which can be repeated as needed. For example, if a patient presents with shallow breathing from a suspected opioid overdose, an initial 0.4 mg dose of naloxone would be appropriate. Remember that 0.4 mg is your standard starting point for naloxone in a breathing patient with opioid overdose. Question 19. A patient experiencing chest pain consistent with acute coronary syndrome, ACS, and having a systolic blood pressure of 90 mm of mercury should not receive which medication? A. Aspirin. B. Oxygen. C. Nitroglycerin. D. Morphine. Answer: C. Nitroglycerin. This question highlights a critical contraindication in ACS management. The important clue is systolic blood pressure of 90 mm of mercury, indicating hypotension. Nitroglycerin, a vasodilator used to reduce chest pain in ACS, is contraindicated in hypotensive patients, typically systolic BP less than 90 mm of mercury, or those with suspected right ventricular infarction, as it can dangerously lower blood pressure further. For example, if a patient with chest pain has a blood pressure of 85/50 mmHg, giving nitroglycerin could cause them to collapse. Always check blood pressure before administering nitroglycerin in ACS. Question 20. When should oxygen be administered to a patient experiencing an acute coronary syndrome? A. Routinely for all patients. B. Only if oxygen saturation is less than 90% or signs of hypoxemia are present. C. Only if the patient complains of shortness of breath. D. Only after other medications have been administered. Answer: B. Only if oxygen saturation is less than 90% or signs of hypoxemia are present. This question tests the updated guidelines for oxygen therapy in ACLS. The keyword "should be administered" requires precise knowledge of the current recommendations. Routine oxygen administration is no longer recommended for all ACLS patients. Instead, oxygen should be given only if the patient is hypoxemic, oxygen saturation less than 90%, or shows signs of hypoxemia or respiratory distress. For instance, if a patient with chest pain has an SpO2 of 95%, supplemental oxygen is not immediately indicated according to current guidelines. Avoid giving oxygen if it's not needed, as too much oxygen can actually be harmful in ACLS. Question 21. Which medication is generally considered the first-line vasopressor for most types of shock, e.g., septic shock, when fluid resuscitation alone is insufficient? A. Dopamine. B. Dobutamine. C. Norepinephrine. D. Epinephrine. Answer: C. Norepinephrine. This question asks about the preferred vasopressor in general shock management. The keywords first-line vasopressor and most types of shock are crucial. Norepinephrine is considered the first-line vasopressor for most types of shock, especially septic shock, because it effectively increases systemic vascular resistance and mean arterial pressure with less arrhythmogenic potential compared to dopamine. For example, if a patient remains hypotensive despite receiving adequate intravenous fluids for suspected sepsis, a norepinephrine infusion would typically be initiated. Remember, norepinephrine is the primary choice when you need to raise blood pressure in shock. Question 22. What is the recommended dose of dextrose 50%, D50, for an adult with symptomatic hypoglycemia who is unconscious? A. 10 to 20 milliliters. B. 25 to 50 milliliters. C. 100 to 250 milliliters. D. 500 milliliters. Answer: B. 25 to 50 milliliters. This question checks the specific volume dose for D50 in an emergency setting. The key terms are dextrose 50%, D50, and symptomatic hypoglycemia who is unconscious. The standard adult dose of D50 is 25 to 50 milliliters, which delivers December 5th, 25 grams of dextrose, given intravenously to rapidly correct low blood sugar. For instance, if a patient has altered mental status and a glucometer reading of 45 milligrams per deciliter, administering 25 to 50 milliliters of D50 would be the appropriate action. Always remember the typical dose of 25 to 50 milliliters for D50 in unconscious hypoglycemia. Question 23. A patient with severe pulmonary edema and normal blood pressure requires diuresis. Which medication is appropriate? A. Dopamine. B. Furosemide. C. Norepinephrine. D. Atropine. Answer: B. Furosemide. This question tests the appropriate medication for fluid overload. The keywords severe pulmonary edema and normal blood pressure indicate a need for fluid removal without immediate vasopressor support. Furosemide, a loop diuretic, is used to promote diuresis and reduce fluid volume in patients with pulmonary edema, thereby alleviating respiratory distress. For example, if a patient has crackles in their lungs and shortness of breath due to fluid overload, administering furosemide will help them excrete excess fluid. When you see pulmonary edema and diuresis, think furosemide. Question 24. What is the appropriate management for a patient in cardiac arrest with suspected hypokalemia, low potassium? A. Magnesium sulfate. B. Calcium chloride. C. Sodium bicarbonate. D. potassium chloride. Answer A. Magnesium sulfate. This question focuses on treating a specific electrolyte abnormality in cardiac arrest. The keyword hypokalemia is the crucial clue. Although hypokalemia is a low potassium level, severe hypokalemia can lead to cardiac arrhythmias, and magnesium sulfate is often co-administered or given in suspected hypokalemia-induced arrhythmias, as hypomagnesemia often coexists and complicates hypokalemia. For example, if lab results show very low potassium and magnesium, administering magnesium sulfate is crucial for cardiac stability. Remember, magnesium sulfate can help stabilize the heart in certain electrolyte imbalances, especially when hypokalemia is a concern. Question 25. Which medication is most appropriate for a patient experiencing chest pain and ST elevation myocardial infarction, STEMI, who also complains of severe anxiety and is restless? A. Aspirin. B. Nitroglycerin. C. Morphine. D. Furosemide. Answer C. Morphine. This question tests the role of morphine in ACS management. The keywords severe anxiety and restless in a STEMI patient are important clues. Morphine is used in STEMI not only for pain relief but also for its anxiolytic, anxiety-reducing, and venodilatory effects, which can help reduce preload and cardiac workload, particularly when anxiety is prominent. For instance, if a STEMI patient remains in severe pain and is highly agitated despite initial nitroglycerin, morphine could be administered to calm them and alleviate discomfort. Consider morphine in ACS for pain and anxiety, especially if other measures aren't enough. Question 26. A patient is unresponsive with a suspected benzodiazepine overdose. Which medication is the specific antidote? A. Naloxone. B. Flumazenol. C. Atropine. D. Dextrose. Answer B. Flumazenol. This question asks about the specific antidote for benzodiazepine overdose. The crucial keywords are unresponsive and benzodiazepine overdose. Flumazenol is a benzodiazepine receptor antagonist that specifically reverses the sedative and respiratory depressant effects of benzodiazepines. For example, if a patient becomes unconscious after taking an unknown number of nerve pills and the pills are identified as benzodiazepines, flumazenol could be administered cautiously. However, it's important to note that flumazenol is used with extreme caution due to the risk of seizures in patients who are chronic benzodiazepine users. Question 27. What is the recommended method for administering adenosine? A. Slow 4-push over 2 minutes. B. Rapid 4-push over 1 to 3 seconds followed by a rapid flush. C. Intramuscular injection. D. Subcutaneous injection. Answer B. Rapid 4-push over 1 to 3 seconds followed by a rapid flush. This question focuses on the proper administration technique for adenosine, which is crucial for its effectiveness. The keyword recommended method points to the specific delivery. Adenosine has an extremely short half-life, only a few seconds, so it must be given as a rapid 4 bolus over 1 to 3 seconds, followed immediately by a rapid 20 ml saline flush to ensure it reaches the central circulation quickly. For instance, administering adenosine too slowly would result in it being metabolized before reaching the heart, rendering it ineffective. Always remember to push adenosine fast and follow it with a quick flush. Question 28. Which medication is indicated for treating bradycardia or asystole in the presence of organophosphate poisoning? A. Epinephrine. B. Atropine. C. Pralidoxime. D. Magnesium sulfate. Answer B. Atropine. This question tests a less common but important indication for atropine. The keywords bradycardia or asystole and organophosphate poisoning are vital. Organophosphate poisoning causes excessive parasympathetic stimulation, leading to profound bradycardia, bronchuria, and other cholinergic symptoms. Atropine is the antidote as it blocks muscarinic receptors. For example, a farmer exposed to pesticides who develops a slow heart rate and excessive secretions would benefit from large doses of atropine. In organophosphate poisoning, atropine is your go-to for reversing the life-threatening cholinergic effects. Question 29. A patient is in cardiac arrest with suspected hyperkalemia. Which medication can be given to stabilize myocardial membranes? A. Sodium bicarbonate. B. Calcium chloride. C. Magnesium sulfate. D. Epinephrine. Answer B. Calcium chloride. This question asks about a specific treatment for a life-threatening electrolyte imbalance in cardiac arrest. The keywords are cardiac arrest and suspected hyperkalemia. Calcium chloride is indicated in hyperkalemia to stabilize the cardiac cell membranes and protect the heart from the adverse effects of high potassium levels, which can include life-threatening arrhythmias. For example, if a patient on dialysis goes into cardiac arrest and hyperkalemia is suspected, calcium chloride can be given to stabilize their heart. Remember that calcium chloride helps protect the heart from the dangers of high potassium. Question 30. What is the primary reason for administering amiodarone in refractory ventricular fibrillation/pulseless ventricular tachycardia? A. To increase heart rate. B. To improve myocardial contractility. C. To suppress ventricular arrhythmias. D. To increase blood pressure. Answer C. To suppress ventricular arrhythmias. This question focuses on the mechanism of action and therapeutic goal of amiodarone in cardiac arrest. The key terms are primary reason and refractory ventricular fibrillation/pulseless ventricular tachycardia. Amiodarone is an antiarrhythmic drug used to suppress ventricular arrhythmias like VF and pulseless VT that persist despite defibrillation and epinephrine, helping to restore an organized rhythm. For example, after multiple shocks fail to convert VF, amiodarone is given specifically to stop the chaotic electrical activity in the ventricles. Think of amiodarone as the drug that calms down and helps reorganize a chaotic, life-threatening heart rhythm. Question 31. Which of the following is an expected, but temporary, side effect of adenosine administration? A. Hypertension. B. Severe chest pain and shortness of breath. C. Bradycardia and flushing. D. Seizures. Answer C. Bradycardia and flushing. This question tests your awareness of the common, transient side effects of adenosine. The keywords expected, but temporary, side effect are crucial. Because adenosine briefly stops the heart to reset the rhythm, patients often experience temporary bradycardia, a very slow heart rate or even a brief pause, flushing, shortness of breath, and chest discomfort, all of which are expected and resolve quickly due to the drug's short half-life. For example, immediately after an adenosine push, a patient might feel an uncomfortable sensation as their heart briefly slows or pauses, which then rapidly resolves. Be sure to warn patients about these sensations before giving adenosine. Question 32. Which medication is appropriate to administer via endotracheal, ET, tube if force/IO access cannot be established in cardiac arrest? A. Amiodarone. B. Sodium bicarbonate. C. Atropine. D. Dextrose. Answer C. Atropine. This question addresses an alternative route of drug administration in emergency situations. The keywords are appropriate to administer via endotracheal (ET) tube and if force/IO access cannot be established. While force/IO is preferred, some medications like lidocaine, epinephrine, atropine, and naloxone, mnemonic, lean, can be given via the ET tube, typically at 2 to 2.5 times the foredose, absorbed through the bronchial tree. For example, if a patient in cardiac arrest cannot get in 4 quickly, atropine could be given via the ET tube. Remember the lean mnemonic for drugs that can be administered via the ET tube. Question 33. What is the most appropriate action if a patient in stable SVT becomes unstable, e.g., hypotensive, altered mental status, after an initial attempt at adenosine administration fails? A. Repeat adenosine 12 mg. B. Prepare for synchronized cardioversion. C. Administer amiodarone. D. Begin CPR. Answer B. Prepare for synchronized cardioversion. This question tests the progression of management for SVT based on patient stability. The key phrases are stable SVT becomes unstable and after an initial attempt at adenosine administration fails. When a patient with SVT becomes unstable, immediate synchronized cardioversion is the priority because the electrical instability, hypotension, altered mental status, signs of shock, demands immediate rhythm conversion. For example, if a patient initially stable with SVT suddenly drops their blood pressure to 70/40 mmHg and becomes unresponsive, electrical cardioversion is urgently needed over further medication. Always remember that patient instability trumps drug therapy and indicates the need for immediate electrical therapy. Question 34. A patient in cardiac arrest has a prolonged QTc interval on ECG, and torsades de pointes is suspected. Which medication should be given? A. Epinephrine. B. Lidocaine. C. Magnesium sulfate. D. Atropine. Answer C. Magnesium sulfate. This question again points to the specific treatment for torsades de pointes. The clues are cardiac arrest, prolonged QTc interval, and torsades de pointes is suspected. Magnesium sulfate is the primary treatment for torsades de pointes, even in cardiac arrest, because it helps stabilize the cardiac membrane and reduce the likelihood of this specific polymorphic ventricular tachycardia. For example, if the monitor shows torsades and the patient is pulseless, administering magnesium sulfate is a critical step in the cardiac arrest algorithm. Torsades de pointes equals magnesium sulfate. Question 35. When administering 4 fluids as part of ACLS, what is the preferred type of fluid for most adult resuscitation? A. Dextrose 5% in water, D5W. B. 0.45% sodium chloride, half normal saline. C. Lactated ringers or normal saline. D. 25% albumin. Answer C. Lactated ringers or normal saline. This question assesses knowledge of basic fluid resuscitation in ACLS. The key phrase, preferred type of fluid for most adult resuscitation, directs you to the standard choices. Isotonic crystalloids, such as lactated ringers or normal saline, 0.9% sodium chloride, are the preferred intravenous fluids for most adult resuscitation scenarios because they effectively expand the intravascular volume without causing significant fluid shifts. For example, if a patient is hypotensive from hypovolemia, a rapid infusion of normal saline or lactated ringers is the initial fluid choice. Always choose isotonic crystalloids for initial fluid resuscitation. Question 36. Which of the following is a contraindication to the administration of nitroglycerin in a patient with chest pain? A. History of hypertension. B. Use of a phosphodiesterase inhibitor, e.g., sildenafil, within 24 to 48 hours. C. Mild headache. D. Age over 70 years. Answer B. Use of a phosphodiesterase inhibitor, e.g., sildenafil, within 24 to 48 hours. This question highlights a critical contraindication for nitroglycerin due to potential for severe hypotension. The crucial clue is contraindication. Nitroglycerin is absolutely contraindicated in patients who have recently taken phosphodiesterase inhibitors, like sildenafil or tadalafil, commonly used for erectile dysfunction, because the combination can cause a profound and life-threatening drop in blood pressure. For example, if a patient with chest pain admits to taking sildenafil within the last 24 hours, nitroglycerin must be avoided. Always ask about recent phosphodiesterase inhibitor use before giving nitroglycerin. Question 37. What is the next step after administering the first dose of amiodarone, 300 mg, for refractory VF/pulseless VT in cardiac arrest? A. Administer lidocaine. B. Administer a second dose of amiodarone. C. Continue CPR and reassess rhythm for defibrillation. D. Administer sodium bicarbonate. Answer C. Continue CPR and reassess rhythm for defibrillation. This question tests the flow of the cardiac arrest algorithm after an antiarrhythmic dose. The keywords next step and first dose of amiodarone are important. After administering any medication in cardiac arrest, it is crucial to continue high-quality CPR and then reassess the rhythm to see if it has changed to a shockable rhythm, preparing for further defibrillation if appropriate. For example, if you give amiodarone, don't stop CPR, keep pushing and then check the rhythm to see if another shock is indicated. Always return to CPR immediately after a drug administration and then check the rhythm for shock readiness. Question 38. A patient is experiencing stable narrow-complex tachycardia unresponsive to vagal maneuvers and adenosine. Which medication might be considered for rate control if the rhythm persists? A. Epinephrine. B. Atropine. C. Diltiazem or beta blockers. D. Norepinephrine. Answer C. Diltiazem or beta blockers. This question addresses further pharmacological management of stable SVT when adenosine is ineffective. The keywords are stable narrow-complex tachycardia, unresponsive to vagal maneuvers and adenosine, and rate control. If adenosine is unsuccessful in converting stable SVT, calcium channel blockers like diltiazem or beta blockers are considered for rate control, especially if cardioversion is not immediately indicated or desired. For instance, if a patient's SVT persists after 2 doses of adenosine but they remain stable, a diltiazem infusion might be started to slow the heart rate. When adenosine fails in stable SVT, think about rate control with diltiazem or beta blockers. Question 39. What is the recommended dose of sodium bicarbonate for indicated situations, e.g., severe acidosis from hyperkalemia or TCA overdose, in cardiac arrest? A. 0.5 milliequivalent/kg4. B. 1 milliequivalent/kg4. C. 2 milliequivalent/kg4. D. 5 milliequivalent/kg4. Answer B. 1 milliequivalent/kg4. This question asks for the specific dose of sodium bicarbonate when it is indicated. The important clue is recommended dose for indicated situations. When sodium bicarbonate is appropriate for severe metabolic acidosis from hyperkalemia or tricyclic antidepressant overdose in cardiac arrest, the recommended dose is 1 milliequivalent/kg/4. For example, if a patient in cardiac arrest has a suspected tricyclic antidepressant overdose, you would calculate and administer 1 milliequivalent/kg of sodium bicarbonate. Remember the 1 milliequivalent/kg dose for sodium bicarbonate in specific, severe acidosis scenarios. Question 40. A patient presents with acute onset chest pain and ST segment elevation on the ECG. What is the recommended initial dose of chewable aspirin? A. 81 milligrams. B. 162 milligrams. C. 162 to 325 milligrams. D. 650 milligrams. Answer: C. 162 to 325 milligrams. This question asks about the specific dose of aspirin in an acute cardiac event. The keywords are initial dose of chewable aspirin and ST segment elevation on the ECG, indicating STEMI. For acute coronary syndromes, the recommended initial dose of chewable aspirin is 162 to 325 milligrams. Chewing the aspirin allows for faster absorption and antiplatelet effect, which is crucial in preventing further clot formation in the heart. For example, if a patient is experiencing a STEMI, providing them with 325 milligrams of chewable aspirin as soon as possible is a critical initial step. Always remember the 162 to 325 milligrams chewable dose for aspirin in ACS. Question 41. Which pressor agent is typically used in cardiogenic shock when associated with significant bradycardia or a need for increased contractility and heart rate? A. Norepinephrine. B. Dopamine. C. Phenylephrine. D. Vasopressin. Answer: B. Dopamine. This question explores a specific indication for dopamine in shock. The key clues are cardiogenic shock and significant bradycardia or a need for increased contractility and heart rate. Dopamine is considered for cardiogenic shock, especially when there is concurrent symptomatic bradycardia or a need for improved myocardial contractility and increased heart rate, as it has both alpha and beta adrenergic effects. For example, if a patient in cardiogenic shock has a very slow heart rate and poor contractility, dopamine might be chosen to improve both. While norepinephrine is often first line for most shock, dopamine can be useful when you need to improve both heart rate and contractility in cardiogenic shock. Question 42. What is the initial recommended dose of 4/IO vasopressin for adult cardiac arrest, if still used in local protocols? A. 10 units. B. 20 units. C. 30 units. D. 40 units. Answer: D. 40 units. This question asks about the dose of vasopressin, a less common but historically relevant cardiac arrest drug. The key phrasing, if still used in local protocols, acknowledges its reduced prominence in recent guidelines compared to epinephrine. While vasopressin has largely been removed from the adult cardiac arrest algorithm in recent AHA guidelines, historically, if used, the recommended single dose was 40 units 4/IO. For example, in some older or specific protocols, 40 units of vasopressin might be given as a one-time dose in cardiac arrest. Focus on epinephrine as the primary vasopressor in cardiac arrest, but be aware of vasopressin's past role and dose if it comes up. Question 43. A patient in cardiac arrest has a suspected massive pulmonary embolism as the cause. Which medication might be considered as part of the management if reperfusion therapies are available? A. Tranexamic acid. B. Alteplase, TPA. C. Amiodarone. D. Aspirin. Answer B. Alteplase, TPA. This question delves into a specific, potentially reversible cause of cardiac arrest. The keywords are cardiac arrest and suspected massive pulmonary embolism. In cardiac arrest due to suspected massive pulmonary embolism, fibrinolytic therapy with agents like alteplase, tissue plasminogen activator or TPA, may be considered to break down the clot-obstructing blood flow, although this is a high-risk intervention with specific criteria. For example, if a patient suddenly collapses after a long flight and signs point to a large PE, TPA might be discussed if other treatments fail. Remember that fibrinolytics are reserved for highly suspected or confirmed PE in cardiac arrest due to their bleeding risks. Question 44. What is the usual initial infusion rate range for nitroglycerin in a patient with ACS and persistent chest pain? A. 1 to 5 mcg/min. B. 5 to 20 mcg/min. C. 20 to 50 mcg/min. D. 50 to 100 mcg/min. Answer B. 5 to 20 mcg/min. This question tests the typical infusion rate for nitroglycerin in ACS. The keywords initial infusion rate range and persistent chest pain are important. After sublingual nitroglycerin, if chest pain persists, and infusion of nitroglycerin is often started, typically at 5 to 20 mcg/min and titrated to effect or blood pressure, as long as the patient is not hypotensive. For instance, if a patient's chest pain doesn't go away with sublingual tabs, a nitroglycerin drip starting at 5 micrograms per minute could be initiated. Remember to titrate nitroglycerin infusions carefully to achieve pain relief while monitoring blood pressure closely. Question 45. Which medication is an inotropic agent that primarily increases myocardial contractility with less effect on heart rate and systemic vascular resistance, often used in decompensated heart failure with low cardiac output? A. Dopamine. B. Norepinephrine. C. Dobutamine. D. Epinephrine. Answer C. Dobutamine. This question asks about a specific type of vasopressor/inotropic agent. The keywords are inotropic agent, primarily increases myocardial contractility, and decompensated heart failure with low cardiac output. Dobutamine is a beta-1 adrenergic agonist that selectively increases myocardial contractility, inotropic effect, with minimal effects on heart rate or systemic vascular resistance at usual doses, making it suitable for improving cardiac output in heart failure. For example, if a patient with severe heart failure has low cardiac output but stable blood pressure, dobutamine might be infused to boost the heart's pumping ability. Dobutamine is your go-to for improving heart squeeze in heart failure. Question 46. A patient with severe symptomatic bradycardia is unresponsive to atropine. What would be the next pharmacologic step, assuming pacing is not immediately available? A. Adenosine. B. Epinephrine infusion or dopamine infusion. C. Amiodarone. D. Lidocaine. Answer B. Epinephrine infusion or dopamine infusion. This question addresses the management of symptomatic bradycardia when the first-line drug fails. The crucial clues are severe symptomatic bradycardia, unresponsive to atropine, and pacing is not immediately available. If atropine fails to improve symptomatic bradycardia, and transcutaneous pacing is not an option, for infusions of epinephrine or dopamine are recommended as temporary measures to increase heart rate and improve perfusion. For example, if a patient remains hypotensive and profoundly bradycardic after maxing out on atropine, starting a dopamine drip would be appropriate while preparing for pacing. When atropine fails for symptomatic bradycardia, think about infusions like epinephrine or dopamine to temporarily support the heart rate. Question 47. What is the purpose of administering 4 fluids in a patient with suspected hypovolemic shock in the absence of acute pulmonary edema? A. To decrease systemic vascular resistance. B. To increase myocardial contractility. C. To expand intravascular volume. D. To correct metabolic acidosis. Answer, C. To expand intravascular volume. This question tests the fundamental reason for fluid administration in a specific type of shock. The keywords are 4 fluids, hypovolemic shock, and absence of acute pulmonary edema. In hypovolemic shock, the primary goal of administering 4 fluids is to replenish lost fluid and expand the intravascular volume, thereby improving blood pressure and tissue perfusion. For example, if a patient is hypotensive after significant bleeding, giving 4 fluids like normal saline helps restore their circulating blood volume. Remember, for hypovolemic shock, fluids are given to fill up the tank. Question 48. In which of the following scenarios would administration of epinephrine not be the first-line treatment? A. Pulseless ventricular tachycardia. B. Asystole. C. Symptomatic bradycardia. D. Ventricular fibrillation. Answer, C. Symptomatic bradycardia. This question aims to distinguish the primary indications for epinephrine in different ACLS scenarios. The key phrase is not be the first-line treatment. While epinephrine is the first-line vasopressor in pulseless cardiac arrest rhythms like pulseless VT, asystole, and VF, after initial shock, it is not the first-line treatment for symptomatic bradycardia, atropine is. For instance, if a patient has a heart rate of 40 bpm and is dizzy, atropine would be given first, not epinephrine. Be careful to differentiate between cardiac arrest, where epinephrine is key, and bradycardia, where atropine comes first. Question 49. What is the recommended dose of lidocaine if a second dose is needed for refractory VF/pulseless VT after an initial dose of 1 to 1.5 mg/kg? A. 0.25 to 0.5 mg/kg. B. 0.5 to 0.75 mg/kg. C. 1 to 1.5 mg/kg. D. 1.5 to 2.0 mg/kg. Answer, B. 0.5 to 0.75 mg/kg. This question explores the subsequent dosing of lidocaine in cardiac arrest. The keywords are recommended dose, second dose, and refractory VF/pulseless VT after an initial dose. If a second dose of lidocaine is required for persistent VF/pulseless VT, the subsequent dose is 0.5 to 0.75 mg/kg, with a maximum total dose of 3 mg per kilogram. For example, if a patient receives 1.5 mg per kilogram lidocaine for VF and remains in the rhythm, a second dose of 0.75 mg per kilogram could be given. Remember that subsequent lidocaine doses are typically half of the initial dose. Question 50. Which medication would be indicated for a patient in cardiac arrest with known end-stage renal disease and signs of hyperkalemia? A. Sodium bicarbonate and calcium chloride. B. Magnesium sulfate and adenosine. C. Furosemide and norepinephrine. D. Aspirin and nitroglycerin. Answer, A. Sodium bicarbonate and calcium chloride. This question presents a complex scenario requiring recognition of specific treatments for hyperkalemia in cardiac arrest. The critical clues are cardiac arrest, end-stage renal disease, and signs of hyperkalemia. In cardiac arrest associated with hyperkalemia, both calcium chloride, to stabilize myocardial membranes and protect against arrhythmia, and sodium bicarbonate, to shift potassium intracellularly and improve acidosis, are crucial. For example, if a patient with kidney failure has a cardiac arrest, these two medications would be immediately considered to counter the effects of high potassium. For hyperkalemia in cardiac arrest, remember to use both calcium chloride and sodium bicarbonate.